So my talk is about non-invasive neuromodulation or electrical brain stimulation for chronic pain, or ways that we could use it in chronic pain. And I'll start with what's probably a deceptively simple question. What is pain? We've all experienced pain. We've all talked about pain at some level over the course of our lives. But what is it really? And the International Association for the Study of Pain has come out and published a definition. And what I highlight here is that there are actually sort of two aspects here. They refer to, it's unpleasant of course, but there's a sensory component and an emotional or mood component, and that this relates to tissue damage in some form. And so while it's digesting for a moment, I'll give a little bit of a sort of a clinical patient story or patient vignette. So for example, we might have a 45-year-old man who's married, has 2 kids, is employed, works in a factory, and does a lot of heavy lifting as part of his work. One day he trips up, falls awkwardly, and injures his back. Might have spinal fracture, goes to the hospital, has a successful surgery to relieve any pressure that might be on the nerves and on the spinal cord, and then is given some small prescription of Percocet to help with the post-surgical pain, and is sent on his way with appropriate follow-up in his primary care doctor's office. Seems relatively straightforward, but over the next 6, 8, 12 months, that pain doesn't go away. He finds himself unable to work, so he no longer has his job. He's not able to lift his kids up or play with his kids, so he's now not doing things that he enjoys. He starts to isolate, starts to stay home, doesn't get outside, bills start to pile up. There's a financial pressure as well. And what happens is, not surprisingly, he gets depressed, he gets anxious, he starts questioning whether life is worth living in this current state. So basically what I've highlighted is we kind of started off with this sensory component, but as time has passed and symptoms have continued, we see more and more of an emotional or psychiatric toll that is taken on the individual. And so to phrase this a different way, we have sort of pain and suffering. So the first bit is this nociceptive or sensory component, and most of us are familiar with that. We've all stubbed our toes or jammed our fingers or something like that, and that's what most people think of when we talk about pain. And that's actually what we're very good at treating right now with opiate pain medications or over-the-counter anti-inflammatories and those sorts of things. What we're not as good at treating is this more lasting and more permanent emotional or mood component, the depression, the anxiety, the avoidance of activities for fear that they might cause pain to be exacerbated. And it's very hard to treat, especially by the time they might come see someone like me in a psychiatric outpatient office. They've been suffering from these symptoms for a very long period of time. And there actually is imaging evidence that suggests that there are some changes in the brain itself that are associated with what we call pain chronification. And most of the current treatments we have are really great at addressing the sensory piece, not so good at addressing that mood piece. And in the patient example that I gave, I focused somewhat deliberately on chronic low back pain because that's one of the most common forms of chronic pain. You can see some of the figures here, which are quite remarkable. Up to 80% of Americans will experience at some point in their lives low back pain. Worldwide, in terms of chronic low back pain, lasting pain, typically defined as being present for more than 6 months, pretty significant fraction of people are affected. Huge numbers of people. And we have treatments to address that sensory piece. Medications, injections, surgeries, all of those things that we have. For the mood component or emotional component, we do have some tools. Cognitive behavioral therapy is great for that, as is biofeedback. But a lot of times it's hard for someone to access these if they are not living near a major academic medical center where there are specialized and trained people to deliver these therapies. So what else can we do to really address both aspects of chronic pain? One thing we've heard a lot about, neuromodulation or electrical stimulation. Now that Shaq is retired, I think he's been doing commercials for this TENS device. And here's an example of one that's a little bit more sort of clinically available. But basically what they're doing is you apply these electrodes at or near the site of pain. So they're working below the neck, if you will. And they're meant to affect the sensory component of pain. Surgeons can also implant electrodes in the spinal canal and stimulate the spinal cord with electrical pulses to achieve the same thing. But once again, all of these are operating below the neck. So we're looking at really the sensory component of it. We're not thinking about what's going on in the brain at the higher levels of processing of painful stimuli. So what can we do there? There seems to be an unmet need. So we heard a little bit earlier about transcranial alternating current stimulation. What I'm talking about today is transcranial direct current stimulation. So there's no oscillation in the current that is applied. It is a constant intensity over typically a 20-minute period of time. It's non-invasive. It can be used to increase or decrease the excitability of brain targets. And it has been demonstrated to be good at improving cognition and pattern recognition. So the military has been interested in using this for training soldiers. And video gamers have used this as well. This is actually a commercial device called Focus that one can buy. And there's a lot of advertising copy on their website about how it will improve your Xbox scores and so forth. So we do see this entering the mainstream. There's also a very active do-it-yourself community of people who make these devices with, they're essentially just battery powered, so with off-the-shelf components and applying it to themselves, which has, its benefits and its risks. So I'll talk a little bit about what has motivated the work that I'm doing under the NARSAD award. So first I conducted a couple of pilot studies with my collaborators in healthy volunteers using something called the cold presser task. And yes, this is a cooler full of ice water that you plunge your hand into. It's a little screen there so that the ice cubes don't actually touch your hand or your arm. And you basically measure pain intensity for the person who stuck their hand in there. And we also measure how long someone can keep their hand inside. I was able to do about 30 seconds, which made me much wimpier than most of the other people who were in the study. But basically, these were just healthy people, so no pain diagnoses. And we looked at two brain targets that you heard about a little bit earlier today, the dorsal anterior cingulate cortex and the dorsolateral prefrontal cortex. And really the upshot of this was a preliminary study, healthy people, but there was some suggestion that we might be able to change a little bit how people perceive their pain with the stimulation. There was a sort of a trend level result here, contrasting these two flavors of stimulation, suggesting it might, maybe if we had a larger sample, have some effect on how long someone can endure having their hand in this bucket of ice water. And we also found that with a different target, there seemed to be a separation here in the pain ratings themselves before and after the task. So what does this mean? Because this was in healthy people, but we're interested in what we could do in actual patients with chronic low back pain. And I'll also point out that these two targets were selected because they are nodes in the pain processing circuitry. The dorsal anterior cingulate in particular is a target for opioid medications. And the dorsolateral prefrontal cortex is implicated in a large number of depressive syndromes and has roles in attention and various other things that are important in the processing of painful stimuli. So, to the work that I'm doing now, due to the generosity of the NARSAD Young Investigator program. So we have a study that's currently ongoing, so I don't have results to present yet, but this is something where we're still collecting data using a research-grade device. So here, once again, battery-powered stimulator, some wires going up to these sponges that are soaked in saline or salt water and are held to the head with just some rubber straps. Pretty simple application of this. These are not the locations we actually use in the study. This is just representative from the manufacturer. But this is a multi-site study. It's placebo-controlled, so people are either receiving active stimulation or sham stimulation or placebo. They don't know which one they're receiving, and I don't. I still don't, actually, because I'm still blinded. And we are only recruiting patients who have diagnosed chronic low back pain. So we review their medical record with the appropriate releases and verify that they have chronic low back pain. And instead of receiving only 1 or 2 sessions, they're actually receiving daily sessions over the course of 2 weeks. And we also have a 6-week post-treatment follow-up. And we're assessing people on a whole battery of scales, measuring pain intensity, pain acceptance, pain-related disability, as well as mood and anxiety scales as well. So we're gathering a large amount of data. So far, we've completed 21 participants who were done at both the Providence VA hospital and also at Butler Hospital, both affiliated with Brown, where I began some of this early work. And I've recently obtained IRB approval to do the same at Brigham and Women's Hospital, where I currently work. We're in the process of doing an interim analysis. Basically, we're trying to see how much statistical power we have with this sample and how many more people we would want to add to the sample to have some hope of showing a potentially significant result. So that work is ongoing, and at the same time, I'm also thinking about where can we take this further after this study is completed. So I mentioned a couple of brain targets, but there are others that are involved in processing pain and intention. So those would be things to think about as well. Also thinking about special participant populations. For example, maybe people who have chronic pain and are also opiate dependent, or people who have chronic pain and also have HIV, for example. These are special populations that we have very little data about at this stage. Also, thinking about combined treatments. For example, I mentioned cognitive behavioral therapy as being effective for that emotional or affective or mood component of pain. What if we combine that with brain stimulation in the form of TDCS, since we saw earlier as well that it seems to help with learning and cognition? What if we combine those two and look for a synergistic or combined effect? So all things that we are thinking about and things that we are actively doing. So I will say watch this space. Like Tracy Butler said, hopefully if I'm invited back at some point, I'll be able to share some results of what this work has shown. And I should end by thanking a huge number of people without the aid of which none of this would have been possible. So key collaborators and mentors at Brown, Ben Greenberg and Fred Burgess. Fred Burgess is an anesthesiologist, so he's really been instrumental in designing the study. I have my NARSAD mentors at Harvard, and a whole slew of other people, too many to name, who have helped with this study as well. Thank you.